So currently, what we know as the status in our country in terms of our mortalities, and I will limit our discussion today to the RAMCA ecosystem. RAMCA stands for Reproductive, Maternal, Newborn, Child, and Adolescent Health. So within that ecosystem, in terms of maternal deaths, we know that maternal mortality rate, currently we are working with 355 deaths per 100,000 live births, which is data from the 2019 census. And therefore, this translates to about 5,000 deaths a year. And when you drill down, you will find we are talking about 13 deaths per day. For the newborns, we are working with a neonatal mortality rate of 21 deaths per 1,000 live births. This is from the KTHS 2022, which then translates to 30,000 deaths per year, and we can all calculate what that translates to on a daily basis. It's very high numbers. The leading causes of these mortalities are outlined in that pictorial. For maternal mortalities, the leading causes are postpartum hemorrhage, antepartum hemorrhage, and eclampsia. So for our colleagues who are newly inaugurated doctors, I hope the acronyms are not intimidating you, but you will learn as we go along. For our neonatal mortalities, the leading cause of death is prematurity or very small babies, the low birth weight babies, birth asphyxia, and sepsis. And we are able to provide more data on this. If you want to interact with more data that is related to your county, please see us sidebar. In terms of how our clients have been accessing services, for the skilled birth attendants, the trend has been rising. That's the chart there. And we see between 1993 and 2022, based on the KDHSs that have been done, there has been a good rise in the trend on access to skilled birth attendants. And yet, our maternal mortalities are not reducing at the same rate. We can see for the maternal mortality rate, there has been coming down since 1998, but seems to be stagnating in the last 4 or 5 years. For the past, call it 5 to 10 years. And the same case for our what you're seeing there is 2 charts, trends of maternal mortality based on KDHS and trends of maternal mortality based on the facility reports we receive from your facilities. So we see that the trend is going down and then stagnating in the course of the past 10 years. Do we report the maternal deaths? This chart tries to show how we compare the number of maternal deaths that are reported by health facilities and the number that are audited. A maternal death is a notifiable condition, and so each death should be audited. And this is demonstrating over the years how are we auditing, the comparison between the reporting and the auditing. There's been an improvement, but we still have areas of building up, and the variations among counties is quite significant. This is a chart showing the facility maternal mortality ratios and data that has been captured from the KHIS. And there we can see there are counties that are doing better than others and vice versa. And feel free to check out where your county lies in terms of this metric. And essentially the message here is that the room for improvement still exists. How do we compare with how we are reporting at the facility and the census data? You can see there's great variation. The discrepancies are huge. The blue bars is the MMR as per the census data, and the orange bars is the facility report, the MMR reported within the facility. So you can see the census data indicates that there are a lot more mortalities that we have not been captured from the facility reports. In terms of our newborn deaths, the picture is somewhat similar. We find that the trends have been reducing, but they are not reducing at the rate that we wish. Our SDG target is to have, to be able to bring down the deaths to 12 deaths per 1,000 live births, and we have a long way to go for that. And similarly, if we compare the reporting of the neonatal mortality rates, comparing the KDHS data and the facility reports, we see again there is quite some discrepancies. Some counties are doing better than others, and so that's an area of growth for us to take note of. So, apologies, it looks like. Okay, this last slide in terms of our situation in the country, we are comparing the reporting of stillbirths and neonatal mortality rate. The blue bars is the facility reported neonatal deaths, and the orange bars is the reporting of stillbirth rate. And we can see again, there's still a discrepancy. Most stillbirths are looking like they are almost double the number of the newborn deaths. So we have some room there to adjust and improve the reporting on that. So in terms of maternal death audits, we are currently implementing this as the initiative called MPDSR. In full, it's maternal, perinatal, death, surveillance, and response, which is an endeavor that has been fronted by WHO to allow countries to identify and document and then respond or action areas that have contributed to deaths of the mothers or the babies at the intrapartum period. So it's a QI approach which has been successfully implemented across the globe. In Kenya, we have been implementing this for almost, I would say, almost 10 years. And so far, if implemented well, it can achieve about 30 to 35% reduction of maternal mortalities. And it is part of the awareness, or every woman, every newborn, everywhere, accountability framework, which Kenya is party to. So presently, I would say that the implementation has continued, and it began in 2016. The first guideline for MPDSR was in 2016. And this has been recently reviewed to the 2024 version. And in that intervening period, we were able to record that we were able to audit 85% of maternal deaths and about 15% of perinatal deaths, and published 2 reports, MPDSR reports, and 2 confidential inquiry on maternal death reports. Now, the 2024 guideline aligns to the updated ICD 11 guidelines and other strategic documents, including Karibuni sana. If you allow me, I will continue. So the 2024 MPDSR guideline aligns now to the WHO ICD 11 guidelines and the prevailing policies and strategic documents for Kenya. And at this time, we are implementing the 2024 guidelines, and despite the challenges that we may have faced in that intervening period before the review, we wish to now update our colleagues as follows. In the immediate term, we will intend to initiate a rapid sensitization of all the subnational MPDSR committees on the revised guidelines beginning from next week, and I believe perhaps you have received this communication from our Director General of Health. Secondly, we plan to integrate the revised and the new tools into the current, into the HIS platforms, that is KHIS and ICHIS. We then will disseminate, train trainers and the practitioners on the revised tools for 15 counties within this financial year. And we will also sustain technical assistance to the subnational levels, including the FBOs and private facilities, so that we improve reporting across all domains of health service provision. We'll also have some learning and knowledge exchange forums, and we are putting together the third national report, which will be published in January 2026. Apologies for that typo. So there you have the pictorials. We have the national guideline of 2024 is that image there, and the other images are the other documents, the reports, and the previous guidelines that have now been outdated. In terms of new child and adolescent deaths, not lost on us that we still have a significant burden of neonatal child and adolescent deaths, and the rate of decline is not as we would desire. And so we are seeking to ride on the learnings from MPDSR to scale the death audits now, not just maternal, but include the newborns, the children, and the adolescents. So we have our first edition, Newborn Child and Adolescent Death Audit Guidelines, that was released last year, November. And the dissemination for this guideline is earmarked to ride along with the MPDSR disseminations. And the training of the review committees has begun. So far, 2 counties, the Siaya and Kisumu, have been trained, and 20 more counties will be trained within this year. Those are the tools that are there for the newborn child and adolescent death audits. And so anticipate for this communication to come through, and engagement of the establishment of the committees and training of these committees, and the rollout alongside MPDSR. Thank you very much.
Thank you, Dr. for that presentation. MPDSR is one important component when we are looking at our RAMCA indicators. So the availability of the tools, the reference materials is a welcome move for us. So Katra will take over the program and let us know what's next.
Thank you so much, Chair of the session, and thank you so much to the presenter. Kindly give her a better applause. We are also live, so we've shared a link. For those who are not here, they can be able to follow that link. Allow me to recognize the presence of PS Oluga. PS, karibu sana. Ganda has distracted, he's not even hearing us. So I know we were supposed to have the next presentation for the inter-county MPDSR, but there is a request from the PS. We were told that the president will be here in Mombasa County at 3 p.m., so he's also required together with the CEC for Health. So there is a request that he need maybe to address us, and then thereafter we can be able to have the other sessions continuing. Is that in agreement? Good. So PS karibu sana. We had heavy discussions yesterday. We have around 38. We have 38 CECs in the room. CECs, and this is a well-attended meeting. In this meeting, we also have the Ministry of Health team, we have the SHA team, we have the Digital Health team. We also have KEMSA here, represented by my sister there. And then we also have the inter-county MPDSR. I really wanted also you to sit through to listen to them, but still I know you can make it, probably if you can come early. I know you are also interested and you attended their side events. So yesterday we discussed so many things, including digital health. Digital health we did today, together with reproductive health, and also we had FCPA Margaret Nyakongo. We had a very, very good discussion with her. And we are also expecting the Auditor General yeah, she's already in the room. Karibu sana, mbona umekaa nyuma? So please let us recognize her. I haven't even seen her. Karibu sana, ungekuja hapa mbele. And so PS, there were a lot of issues that was discussed. We had a heavy debate on SHA. And we always say like, wenye wako kwa ground ndio wanajua mambo vile inafanyika. Sisi we are talking up from, tunaongea tukiwa Nairobi. So I know there have been a lot of things. Most of the things also have been discussed during the council meeting. But nevertheless, I felt that the discussions that was on the floor yesterday was quite heavy. There were unresolved issues. So this morning we were even expecting the CEO SHA and the CEO Digital Health. Remember, we were told they will be here. You are in that meeting. But we had to do some of the things. We packed some of the resolutions that we had and some of the unresolved issue so that it can be addressed today. So today you will be wearing 2 shoes. You will be wearing the shoes of Mwangangi, the CEO SHA, and the technical team is here, but there are things that have not been resolved. So you have to put on that shoes, and you will also put on the shoe of the Digital Health CEO, who is not also here. And PS, I feel it's very, very important when we have the executive meeting to have the CEOs who can be able to make decision in this meeting when it is being addressed. Sometimes we send the other officers who cannot be able to make decision here, and they actually refer to the later discussion, basically giving feedback, which sometimes you don't get. So I think it's important, and the CCs here can attest, together with the Secretariat, most of the times the issue of SHA, we are given link to join, we are told coordinate for us, we want to talk to the counties, we want to give them updates, and we ambush counties and we let them get in. But when we have this platform, we have given them this platform to come and actually address them so that we can iron and have a very constructive discussion. So that's our biggest problem. I know even when we were down there during tea break, the CCs have actually raised it. We are calling people and people are not coming to our meeting. But nevertheless, we really appreciate you here. And as PS, I think you can be able and you have the capacity to address most of those issues. As I told you, Ari alone, you'll have 2 shoes plus you as 3 shoes. So allow me to basically invite Dr. Ganda to officially again invite you, and then probably before you say something, he can also project some of the things that we've discussed yesterday which are unresolved, so that you can be able, as you give your remarks and address them, you can be able to address those. So karibu sana, and let us give him a better applause. Thank you so much. So Ganda, the mic is yours from now.
Thank you very much, PS Oluga, for finding time for us at this caucus meeting. This has been a very interesting caucus meeting. We had very serious discussions yesterday, and we continued today. But there are very many unresolved things that were left that were supposed to be discussed today when probably CS was here, or the PS and the SHA leadership. But unfortunately, they are not here. So you might not be able to answer all of them, but it is good for you to know as the accounting officer for the whole of the Department of Health on some of these issues. Are they going to be projected, or did I speak off the cuff? You can still continue as project. Okay, I will say my own things. You give me the platform to use. Anyway, on SHA, I think there are several issues that we were concerned about. One, there is quite a high amount of money which has been rejected for payment, and yet the reasons have not been given by SHA. And the concern is that these services which were offered, some of them used supplies from KEMSA, some of them used